Hello, my name is Dr. Allison Hotujec, and I'm a third-year resident in the University of Wisconsin Family Medicine Residency Program in Madison, Wisconsin. We have already reviewed interpretation of arterial blood gases in a previous podcast. I would recommend reviewing that podcast before listening to today's lecture. In today's podcast, we are going to be discussing some examples of interpreting ABGs using the methods discussed in the previous lecture. We'll briefly review the approach to ABG interpretation. Recall that the first step is to look at the pH and determine if the patient has an acidosis or alkalosis. The next step is then to look at the CO2 and bicarbonate levels and determine if the process is primarily respiratory or metabolic in nature. If it is a primary respiratory process, the next step is to assess if there is appropriate metabolic compensation. This can help clue us in as to whether or not this is an acute or chronic process. If the primary process is a metabolic acidosis, we must calculate the anion gap. If the anion gap is elevated, this narrows our differential diagnosis. In an anion gap metabolic acidosis, we must also calculate the delta-delta, which helps us determine if there is a concurrent metabolic disorder also occurring. Finally, in a metabolic process, we must determine if there is appropriate respiratory compensation. Let's go through some cases to practice this method. Our first case is a 24-year-old man who is found down outside a local bar. He is brought in by EMS and is noted to be quite somnolent, only grimacing slightly to sternal rub. His respiratory rate is 6 and his breaths are quite shallow. An ABG is obtained in the ER, which demonstrates the following. pH is 7.2, PCO2 60, PO2 65, and bicarb of 26. Before we start to assess his acid-base status, don't forget to take note that this patient is hypoxic. His PO2 is only 65. The pH of 7.2 shows that the patient is acidotic as well. In an acidosis, if the CO2 is high, then it's a respiratory acidosis, and if the bicarb is low, then it's a metabolic acidosis. The CO2 is indeed high at 60, and the bicarb is actually slightly increased, so we know this is a primary respiratory acidosis. Recall from our previous lecture that in an acute respiratory acidosis, bicarb rises by 0.1 for every 1 millimeter mercury increase in PCO2, and in a chronic respiratory acidosis, the bicarb rises by 0.4 for every 1 millimeter mercury increase in PCO2. This patient's CO2 is 20 millimeters of mercury higher than we would expect, right? If this is an acute process, the bicarb should rise by 0.1 times 20, or 2. If this were a chronic respiratory acidosis, the bicarb should be elevated by 0.4 times 20, or 8. This patient's results look more consistent with an acute process because the bicarb is only slightly elevated by 2. This patient has an acute respiratory acidosis, possibly caused by respiratory depression from intoxication. Let's do another case. This patient is a 68-year-old man with known COPD who has an ABG performed in your office as part of a COPD assessment. He has a pH of 7.39, PO2 of 80, PCO2 of 55, and bicarb of 30. This patient is neither acidemic nor alkalotic. He has a normal pH, right? His PO2 is on the low end of normal, which is usual for many COPD patients. His PCO2 is elevated from the normal range to 55. His bicarb is also elevated from normal at 30. Let's take a look at that. In a chronic respiratory acidosis, which COPD patients are prone to having, the bicarb should increase by 0.4 times the increase in CO2. If this occurs, then there will be appropriate metabolic compensation. For this patient, CO2 is increased above normal by 15, and 15 times 0.4 is 6. So the bicarb should be increased by 6. A normal bicarbonate level is 24, and 24 plus 6 is 30. This patient's bicarb level is indeed 30, so we know that there is appropriate metabolic compensation. This patient has a chronic respiratory acidosis from his COPD with appropriate metabolic compensation. In our next case, we have a 75-year-old woman admitted with urosepsis. Her blood gas shows a pH of 7.34, PO2 of 90, PCO2 of 35, and a bicarb of 18. Her pH shows she is slightly acidemic. The bicarb is low, which means this is a primary metabolic acidosis. We know it's not a respiratory acidosis because the PCO2 would be elevated in a respiratory acidosis, and her PCO2 is low. Our next step is to determine if it is an anion gap metabolic acidosis or a non-anion gap metabolic acidosis. Her sodium minus her chloride minus the bicarb is equal to 18. This patient has an elevated anion gap metabolic acidosis. In patients with sepsis, lactic acidosis is frequently the cause of an elevated anion gap. We should next calculate the delta-delta to ensure there isn't a concurrent metabolic process. We take the calculated anion gap, 18, minus the expected anion gap of 12. This equals 6. We divide this by the normal bicarb minus the actual bicarb, which is also 6. 6 divided by 6 is 1, and a delta-delta of 1 indicates a pure anion gap metabolic acidosis. Finally, we should see if there is appropriate respiratory compensation. We use Winter's formula for this. The CO2 should equal 1.5 times the bicarb plus 8, which is 35. Our patient's CO2 is 35, so we know she has appropriate respiratory compensation. This patient has an anion gap metabolic acidosis with respiratory compensation. In our next case, another patient of yours with long-standing COPD comes to the emergency department with a one-day history of worsening dyspnea and cough. An ABG is obtained and demonstrates a pH of 7.19, PO2 of 75, PCO2 of 92, and a bicarb of 33. First, note that the patient is hypoxic. He is also acidotic. His PCO2 is greatly elevated to 92, so this is a respiratory acidosis. The next step is to determine if this is acute or chronic. If this were a chronic acidosis, the bicarb should increase by 0.4 for every 1 millimeter mercury increase in CO2. The CO2 is 52 millimeters of mercury above normal, so if this were a chronic process, the bicarb should be elevated by 0.4 times 52, or 21. The bicarb is not increased that much. In an acute process, the bicarb should increase by 0.1 for every 1 millimeter mercury increase in CO2. This would be about 5. The bicarb is increased by more than 5, however. This is a case of a mixed acute on chronic respiratory acidosis. The patient probably has an elevated bicarb and CO2 at baseline, like the patient we discussed in case number 2. Now he is having an acute COPD exacerbation, and his CO2 is suddenly worsened. This causes a worsening respiratory acidosis. While his bicarb may be slightly increased from baseline, he has not yet had time to develop an appropriate metabolic compensation. In our next case, we have a 25-year-old woman who presents to the ED immediately following a sudden onset of pleuritic chest pain and dyspnea. She is otherwise healthy, and the only medication she is on is a combination oral contraceptive pill. She is hypoxic with a PO2 of 75. Her pH is 7.5, so she is alkalotic. Her PCO2 is low, so this is a respiratory alkalosis. The patient is probably hyperventilating because of her dyspnea. Recall that in an acute respiratory alkalosis, the bicarb should decrease by 0.2 for every 1 millimeter mercury decrease in CO2. In a chronic process, the bicarb should decrease by 0.4 for every 1 millimeter mercury decrease in CO2. In this case, the patient's bicarb is normal. She presented to the ER immediately after her symptoms started, so her body has not yet had time to develop a metabolic compensation. She has an acute, uncompensated respiratory alkalosis. Additionally, her clinical picture is concerning for pulmonary embolism. In our final case, we have a 45-year-old man who is hospitalized for a small bowel obstruction and has an NG tube set to suction. He has been receiving opioids for pain control. He becomes somnolent, so a blood gas is obtained. His pH shows a mild alkalosis, and his bicarb is elevated, so it's a metabolic alkalosis. Patients undergoing NG tube aspiration can be prone to metabolic alkalosis due to removal of hydrogen ions in gastric secretions. The next step for a metabolic alkalosis is to determine the respiratory compensation. The CO2 should be equal to roughly 0.7 times the bicarb plus 40. This would be about 60. This patient's CO2 is even higher at 70, which suggests there is a concurrent respiratory acidosis. This is probably because the patient is somnolent and not respirating appropriately. This patient has a primary metabolic alkalosis with a superimposed respiratory acidosis. Hopefully these cases have been helpful in practicing how to interpret arterial blood gases. The most important thing to keep in mind is that if you have a systematic way to approach blood gas interpretation, it makes it a lot easier. The cases you see in the real world will often not be as straightforward as these examples. However, having an appreciation for the basic interpretation of ABGs will get you started in the right direction.